After discussing the direct-acting alpha-adrenergic agonists, let's now move on to the direct-acting beta-adrenergic agonists. In this lecture, we'll discuss the drugs that activate both beta-1 and beta-2 adrenergic receptors, as well as the drugs that selectively activate beta-2 adrenergic receptors. The most important clinical use of beta-adrenergic agonists is the treatment of bronchoconstriction in patients with asthma and COPD, where stimulation of beta-2 receptors produces bronchodilation. The development of beta-2 selective agonists has made these drugs much safer by minimizing unwanted stimulation of beta-1 receptors in the heart, thereby reducing cardiovascular adverse effects. In addition to their respiratory effects, beta-adrenergic agonists are also used in certain cardiovascular emergencies. By stimulating beta-1 receptors, they increase both the heart rate and the force of cardiac contraction, making them useful in conditions such as symptomatic bradycardia, acute heart failure, and cardiogenic shock. Before we discuss these drugs, it's important to understand the location and functions of the beta-1 and beta-2 adrenergic receptors. We've already covered these receptors in detail in our previous lectures, so if you haven't watched them yet, I highly recommend doing so first. Once you're familiar with the receptors, understanding the actions, clinical uses, and adverse effects of beta-adrenergic agonists becomes much easier. Now, just as we did with the alpha-adrenergic agonists, let's first understand the tracing produced by a non-selective beta-adrenergic agonist, that is, a drug which stimulates both beta-1 and beta-2 receptors. Before looking at the tracing, ask yourself an important question. What effect will stimulation of each receptor produce? Let's begin with the beta-1 receptors. These receptors are located primarily in the heart. Their stimulation increases the heart rate, increases the force of cardiac contraction, and therefore increases cardiac output. On the tracing, an increase in heart rate means the peaks will appear closer together, indicating that the heart is beating faster. Next, consider the beta-2 receptors, which are present on the vascular smooth muscle supplying skeletal muscles. Stimulation of these receptors causes vasodilation, leading to a decrease in total peripheral resistance. As the resistance falls, diastolic blood pressure decreases. At the same time, the increased contractility produced by beta-1 stimulation raises the systolic blood pressure by increasing the stroke volume. As a result, the difference between systolic and diastolic pressure becomes larger, producing a wider pulse pressure. Now, let's combine these effects on the tracing. The peaks become closer together because the heart rate has increased. At the same time, beta-1 receptor stimulation increases systolic blood pressure, while beta-2 receptor stimulation decreases diastolic blood pressure. Since pulse pressure is the difference between systolic and diastolic blood pressure, an increase in systolic blood pressure together with a decrease in diastolic blood pressure results in a widening of the pulse pressure. Now, what happens to the mean arterial pressure? Remember that MAP is determined by both cardiac output and total peripheral resistance. Beta-1 stimulation increases cardiac output by increasing the heart rate and the force of cardiac contraction, whereas beta-2 stimulation decreases total peripheral resistance by causing vasodilation. Although cardiac output increases, the fall in total peripheral resistance is usually greater, so the mean arterial pressure shifts slightly downward on the tracing. So, a non-selective beta-agonist produces 4 characteristic changes on the tracing: an increase in heart rate, an increase in systolic blood pressure, a decrease in diastolic blood pressure, and a widened pulse pressure with a slight reduction in mean arterial pressure. Before we understand how drugs change systolic and diastolic blood pressure, let's first understand what these two pressures normally represent. Imagine the heart as a water pump and the arteries as a system of garden hoses. Every time the pump contracts, it pushes a surge of water into the hose, creating the highest pressure inside the hose. This peak pressure is analogous to the systolic blood pressure, the maximum pressure in the arteries when the ventricles contract and eject blood. After the pump stops, water continues to flow through the hose. But because the pump is no longer pushing, the pressure gradually falls. However, it doesn't fall to zero because the hose remains filled with water and its elastic walls help maintain pressure until the next pump. This lowest pressure, just before the next contraction, is analogous to the diastolic blood pressure, the minimum pressure in the arteries when the ventricles are relaxed between heartbeats. So, in simple terms, systolic blood pressure is the pressure created while the heart is actively pumping, whereas diastolic blood pressure is the pressure that remains in the arteries between two heartbeats. Now, if the pump suddenly becomes more powerful and pushes a larger volume of water with greater force, the pressure inside the hose during that pumping phase rises. This is exactly what happens when beta-1 receptors are stimulated. They increase the force of cardiac contraction, which increases stroke volume and cardiac output. As a result, more blood is ejected into the arteries with each heartbeat, causing the systolic blood pressure to increase. Now, let's look at the blood vessels. Imagine that the hose suddenly becomes wider. Water can now flow through it much more easily because there is less resistance. As the water flows away more freely between one beat and the next, the pressure inside the hose falls. This is similar to what happens when beta-2 receptors are stimulated. They cause vasodilation, which decreases total peripheral resistance. Because blood leaves the arterial system more easily during the relaxation phase of the cardiac cycle, the diastolic blood pressure decreases. Now let's apply this concept to a non-selective beta-adrenergic agonist. These drugs stimulate both beta-1 and beta-2 receptors simultaneously. Beta-1 receptor stimulation increases the force of cardiac contraction and cardiac output, which tends to increase the systolic blood pressure. At the same time, beta-2 receptor stimulation causes vasodilation, reducing total peripheral resistance and therefore decreasing the diastolic blood pressure. Although the increase in cardiac output tends to raise the systolic pressure, the simultaneous relaxation of the blood vessels partially offsets this effect. As a result, the systolic blood pressure usually increases only slightly or may even remain nearly unchanged, while the diastolic blood pressure decreases. Consequently, the difference between systolic and diastolic pressure, that is, the pulse pressure, becomes wider. I hope that makes sense. Now, who are your non-selective beta-agonists? The answer is isoproterenol. Isoproterenol is a potent, non-selective beta-adrenergic agonist, meaning it activates both beta-1 and beta-2 receptors, while having virtually no activity at alpha receptors. Let's understand its actions. As we discuss above, beta-1 receptor stimulation increases the heart rate, increases the force of cardiac contraction, and therefore increases cardiac output. At the same time, beta-2 receptor stimulation causes vasodilation, particularly in the blood vessels supplying skeletal muscles, resulting in a decrease in total peripheral resistance. Consequently, diastolic blood pressure decreases, while the increase in cardiac contractility causes systolic blood pressure to remain unchanged or increase slightly. As a result, the pulse pressure widens, and because the fall in total peripheral resistance generally outweighs the increase in cardiac output, the mean arterial pressure decreases slightly. Besides its cardiovascular effects, beta-2 receptor stimulation also produces bronchodilation, making isoproterenol effective in relieving bronchospasm in patients with asthma and COPD. However, because isoproterenol is a non-selective beta-agonist, it simultaneously stimulates beta-1 receptors in the heart, often causing tachycardia and palpitations when used for these respiratory conditions. For this reason, selective beta-2 agonists such as salbutamol are now preferred for the treatment of asthma and COPD, as they provide effective bronchodilation with significantly fewer cardiovascular adverse effects. Today, the clinical use of isoproterenol is limited. As it stimulates beta-1 receptors, it increases the heart rate and the force of cardiac contraction, making it useful in certain cardiovascular emergencies, particularly in patients with symptomatic bradycardia or heart block, where a temporary increase in heart rate is needed until definitive treatment, such as cardiac pacing, can be performed. However, Because isoproterenol also strongly stimulates beta-1 receptors, it commonly causes palpitations and tachycardia, and excessive stimulation may precipitate arrhythmias or worsen myocardial ischemia, especially in patients with underlying coronary artery disease. Now, let's move on to another very important beta-adrenergic agonist, dobutamine. Unlike isoproterenol, which stimulates both beta-1 and beta-2 receptors, dobutamine acts predominantly on beta-1 receptors, although it also has weak activity at beta-2 and alpha-1 receptors. These vascular effects largely cancel each other out. As beta-2 receptor stimulation causes vasodilation, thereby decreasing total peripheral resistance, whereas alpha-1 receptor stimulation causes vasoconstriction and increasing total peripheral resistance. Since these opposing effects offset one another, total peripheral resistance changes very little. Therefore, the predominant effect of dobutamine is on the heart rather than the blood vessels. One important point to remember is that since dobutamine stimulates beta-1 receptors, it produces all the typical beta-1 effects: positive chronotropy, positive dromotropy, and positive inotropy. However, unlike isoproterenol, these effects are not equally prominent. The increase in myocardial contractility is much greater than the increase in heart rate. In other words, dobutamine mainly makes the heart pump harder rather than much faster. In addition, unlike isoproterenol, dobutamine produces very little beta-2 mediated vasodilation, so blood pressure remains relatively stable and there is minimal activation of the baroreceptor reflex. As a result, there is very little additional reflex tachycardia. This is why dobutamine is described as a predominantly positive inotropic agent, even though it also produces positive chronotropic and dromotropic effects. Since total peripheral resistance remains relatively unchanged, so blood pressure changes very little. This makes dobutamine an ideal drug when the primary goal is to improve the pumping ability of the heart without producing marked vasodilation. Because of these pharmacological properties, dobutamine is used mainly for the short-term treatment of acute heart failure and cardiogenic shock, especially when the heart is unable to pump enough blood to meet the body's demands. By increasing myocardial contractility and cardiac output, it improves tissue perfusion without causing a substantial increase in total peripheral resistance. Like all beta-1 agonists, dobutamine can produce tachycardia, palpitations, and cardiac arrhythmias, particularly at higher doses. It also increases the oxygen demand of the myocardium, so it should be used cautiously in patients with ischemic heart disease, where excessive cardiac stimulation may worsen myocardial ischemia. Now, let's move on to the beta-2 selective adrenergic agonists. Before discussing these drugs individually, let's first understand why they were developed. We learned that drugs such as isoproterenol stimulate both beta-1 and beta-2 receptors. While beta-2 receptor stimulation produces the desired bronchodilation, simultaneous beta-1 receptor stimulation in the heart can cause unwanted cardiovascular adverse effects, such as tachycardia and palpitations. To overcome this problem, beta-2 selective agonists were developed. These drugs preferentially stimulate beta-2 receptors, producing effective bronchodilation with much fewer cardiovascular adverse effects. However, it is important to remember that this beta-2 selectivity is relative, not absolute. At higher doses, these drugs begin to lose their selectivity and can also stimulate beta-1 receptors, leading to tachycardia and palpitations. Another major advancement in the development of beta-2 agonists was the modification of their chemical structure. These structural changes made many of these drugs resistant to metabolism by catechol O-methyltransferase, increased their duration of action, and improved the oral bioavailability of some agents. Examples include metoprolol, Terbutaline, and Albuterol. An even more effective strategy to minimize systemic adverse effects is to administer these drugs by the inhalational route. When inhaled as an aerosol, only a small dose is delivered directly to the bronchial smooth muscle, where it activates beta-2 receptors and produces rapid bronchodilation. Because only a small amount reaches the systemic circulation, there is much less stimulation of cardiac beta receptors, reducing cardiovascular adverse effects. In addition, lower systemic concentrations also reduce stimulation of beta-2 receptors in skeletal muscles, thereby decreasing the risk of tremor, which is a common dose-related adverse effect. The onset of bronchodilation also depends on the route of administration. Subcutaneous injection produces rapid bronchodilation, whereas orally administered drugs may require several hours to reach their maximum effect. Inhaled beta-2 agonists usually produce bronchodilation within a few minutes, making them the preferred route for rapid relief of bronchospasm. An important exception is Salmeterol, which has a slower onset of action despite being administered by inhalation. Finally, let's understand how beta-2 agonists improve asthma and COPD. Their primary action is to relax bronchial smooth muscle, producing bronchodilation and reducing airway resistance. In addition, they help suppress the release of inflammatory mediators such as histamine and leukotrienes from mast cells, improve mucociliary clearance, decrease microvascular permeability, and may also inhibit phospholipase A2 activity. However, it is important to remember that asthma is fundamentally an inflammatory disease, and bronchodilation alone does not adequately control airway inflammation. For this reason, inhaled corticosteroids remain the cornerstone of long-term asthma management, and long-acting beta-2 agonists should not be used alone in asthma. Instead, they should always be used in combination with an inhaled corticosteroid to achieve both bronchodilation and control of airway inflammation. Now, among the beta-2 selective adrenergic agonists, Salmeterol and Formoterol are the long-acting beta-2 agonists, whereas Metoprotrenol, Albuterol, also known as Salbutamol, Terbutaline, and Ritodrine are short-acting beta-2 agonists. Let's first discuss the short-acting beta-2 agonists, as they are commonly used for the rapid relief of bronchospasm. Terbutaline, a short-acting beta-2 selective adrenergic agonist. Like other beta-2 agonists, terbutaline produces bronchodilation by relaxing the bronchial smooth muscle, making it useful in the treatment of asthma and chronic obstructive pulmonary disease. One important structural feature of terbutaline is that it contains a resorcinol ring instead of the typical catechol structure. As a result, it is not metabolized by catechol O-methyltransferase. This gives the drug a longer duration of action than catecholamines and also makes it effective when administered orally, in addition to subcutaneous injection and inhalation. The onset of action depends on the route of administration. Following inhalation or subcutaneous injection, bronchodilation occurs rapidly, and after inhalation, the effect usually lasts for about 3 to 6 hours. In contrast, when given orally, the onset of action is slower, typically taking 1 to 2 hours, because the drug must first be absorbed from the gastrointestinal tract before reaching the systemic circulation. Clinically, terbutaline is used for the long-term management of obstructive airway diseases, as well as for the rapid relief of acute bronchospasm. In addition, because it is available in parenteral form, it can also be used in the emergency treatment of status asthmaticus when rapid bronchodilation is required. Now let's discuss salbutamol, also known as albuterol in the United States. It is a short-acting selective beta-2 adrenergic agonist and is one of the most commonly used rescue medications for patients with asthma and COPD. Like terbutaline, salbutamol stimulates beta-2 receptors in the bronchial smooth muscle, producing rapid bronchodilation and relieving bronchospasm. Salbutamol can be administered by inhalation or orally. When given by inhalation, it acts rapidly, producing significant bronchodilation within about 15 minutes, and its effects generally last for 3 to 4 hours. Although salbutamol is used primarily to treat bronchospasm, oral salbutamol can also relax the uterine smooth muscle through beta-2 receptor stimulation, allowing it to delay preterm labor. However, This use is uncommon today because more suitable tocolytic agents are available. Now let's move on to the long-acting beta-2 selective adrenergic agonists, beginning with Salmeterol. Unlike salbutamol and terbutaline, which provide rapid but short-lasting bronchodilation, Salmeterol is a highly lipophilic beta-2 selective agonist with a prolonged duration of action of more than 12 hours. In addition, its selectivity for beta-2 receptors is approximately 50 times greater than that of salbutamol, allowing it to produce sustained bronchodilation with relatively few cardiovascular adverse effects. Because of its prolonged action, Salmeterol provides long-lasting symptomatic relief, improves lung function, and enhances the quality of life of patients with COPD. It is also effective in the long-term management of asthma and has been shown to be as effective as ipratropium, more effective than theophylline, and to produce additive bronchodilation when used together with inhaled ipratropium or oral theophylline. In addition to bronchodilation, Salmeterol may also possess mild anti-inflammatory activity. However, despite being inhaled, Salmeterol has a relatively slow onset of action. Therefore, it should never be used for the rapid relief of an acute asthma attack or sudden bronchospasm. In such situations, a short-acting beta-2 agonist such as salbutamol should be used because it acts within minutes. Salmeterol is metabolized primarily by CYP3A4 to alpha-hydroxysalmeterol, and its metabolites are eliminated mainly in the feces. Clinically, this is important because drugs that inhibit CYP3A4 such as ketoconazole, itraconazole, clarithromycin, or ritonavir can increase the plasma concentration of salmeterol, thereby increasing the risk of systemic beta-2 mediated adverse effects, including tachycardia, palpitations, and hypokalemia. Clinically, salmeterol, along with formoterol, is one of the preferred long-acting beta-2 agonists for patients with persistent asthma, especially those who continue to have symptoms despite appropriate anti-inflammatory therapy. It is also particularly useful in controlling nocturnal asthma because its bronchodilator effect lasts throughout the night. Like other beta-2 agonists, salmeterol can stimulate beta-2 receptors outside the lungs, producing adverse effects such as tachycardia, tremor, an increase in blood glucose, and a decrease in plasma potassium concentration. Because of its long duration of action, it should not be used more than twice daily, typically once in the morning and once in the evening. One final and very important clinical point. As we discussed above, salmeterol should never be used as monotherapy in asthma. Asthma is fundamentally an inflammatory disease, and while salmeterol effectively relieves bronchoconstriction, it does not adequately control airway inflammation. Therefore, it should always be used in combination with an inhaled corticosteroid. For this reason, fixed-dose combinations such as salmeterol plus fluticasone are widely used in clinical practice. Earlier studies raised concerns about an increased risk of severe or even fatal asthma attacks when LABA were used alone without adequate anti-inflammatory therapy. However, this increased risk has not been observed when LABA are used together with inhaled corticosteroids, which is why current treatment guidelines recommend LABA only in combination with an inhaled corticosteroid for asthma, particularly when inhaled corticosteroids alone fail to provide adequate symptom control. Like salmeterol, formoterol should not be used alone in patients with asthma. Instead, it should always be prescribed in combination with an inhaled corticosteroid to control the underlying airway inflammation. For this reason, fixed-dose combinations such as formoterol with budesonide or formoterol with mometasone are widely used in the long-term management of asthma and COPD. Finally, let's discuss Ritodrine, another beta-2 selective adrenergic agonist. Unlike the other beta-2 agonists that we have discussed so far, Ritodrine was developed specifically as a uterine relaxant rather than as a bronchodilator. Remember that beta-2 receptors are present not only in the bronchi but also in the smooth muscle of the uterus. Therefore, stimulation of these receptors causes relaxation of the uterine smooth muscle, reducing the frequency and strength of uterine contractions. Because of this effect, Ritodrine has been used to delay premature labor, providing additional time for fetal lung maturation or for transferring the mother to a facility with appropriate neonatal care. The pharmacological properties of Ritodrine are similar to those of other beta-2 selective agonists. It is rapidly but incompletely absorbed after oral administration, with only about 30% of the oral dose being absorbed. In selected patients requiring rapid uterine relaxation, it can also be administered intravenously. However, clinical studies have shown that beta-2 agonists provide limited improvement in perinatal outcomes, while increasing the risk of maternal adverse effects, particularly cardiovascular complications. For this reason, Ritodrine is rarely used today and is no longer available in the United States, with other tocolytic agents generally being preferred for the management of preterm labor. Now that we've discussed the different beta-2 selective adrenergic agonists, let's understand their adverse effects. Most of these adverse effects occur because of excessive stimulation of beta receptors, especially when the drugs are given in high doses or by oral or parenteral routes, where larger amounts of the drug enter the systemic circulation. One of the most common adverse effects is tremor. This occurs because beta-2 receptors are present in skeletal muscles, and their stimulation increases muscle activity, producing a fine tremor, particularly of the hands. Fortunately, patients often develop tolerance to this effect with continued therapy. When oral treatment is required, starting with a low dose and gradually increasing it can further reduce the severity of tremor. Another important adverse effect is tachycardia. Although these drugs are designed to selectively stimulate beta-2 receptors, this selectivity is not absolute. At higher doses, they may also stimulate beta-1 receptors in the heart. In addition, the heart itself contains beta-2 receptors, and beta-2 mediated vasodilation can activate the baroreceptor reflex, further increasing the heart rate. As a result, patients may experience palpitations and tachycardia, particularly with systemic administration. While serious arrhythmias or myocardial ischemia are uncommon in healthy individuals, patients with coronary artery disease or pre-existing cardiac arrhythmias are at a much higher risk. So, caution is also advised when beta-2 agonists are used in patients taking monoamine oxidase inhibitors or other sympathomimetic drugs, as cardiovascular adverse effects may be enhanced. Because beta-2 receptors are also present in several metabolic tissues, systemic administration of these drugs can produce important metabolic effects. They stimulate glycogenolysis and lipolysis, leading to increased plasma concentrations of glucose, lactate, and free fatty acids. So, in patients with diabetes mellitus, beta-2 agonists may also worsen hyperglycemia, occasionally requiring an increase in insulin dosage. Another important metabolic effect of beta-2 agonists is that they drive potassium from the blood into the cells, leading to a decrease in serum potassium concentration, a condition known as hypokalemia. This occurs because beta-2 receptor stimulation activates the sodium-potassium ATPase pump in skeletal muscle and other tissues. The pump transports potassium into the cells while moving sodium out. So although the total amount of potassium in the body remains the same, the potassium level in the blood decreases. Why is this clinically important? Potassium plays a crucial role in maintaining the normal electrical activity of the heart. When the serum potassium level falls, the heart becomes more electrically unstable, increasing the risk of cardiac arrhythmias. This risk is even greater in patients taking diuretics, because many diuretics, such as furosemide and thiazide diuretics, also lower serum potassium. In addition, hypokalemia increases the sensitivity of the heart to digoxin, making digoxin toxicity more likely and further increasing the risk of serious arrhythmias. Therefore, beta-2 agonists should be used cautiously in patients with heart disease, especially those receiving digoxin or potassium-wasting diuretics. Some patients also experience restlessness, apprehension, or anxiety, particularly when these drugs are given orally or by injection, because systemic exposure is much greater than with inhalational therapy. Finally, long-acting beta-2 agonists used in the treatment of COPD, particularly when combined with inhaled corticosteroids, have been associated with an increased incidence of pneumonia, and patients receiving these therapies should be monitored appropriately. In experimental animals, very large doses of beta-adrenergic agonists have been shown to produce myocardial necrosis, although this is not a typical adverse effect seen with therapeutic doses in clinical practice.